This talk is about pattern reversal visual evoked potential interpretation. It is intended for the clinical neurophysiology fellows at Nick Laus Children's Hospital. I will conduct this talk by showing you a pattern reversal visual evoked potential study and asking you to choose the correct answer. Then I will show you an abbreviated step-by-step approach to finding the correct answer, hopefully the same one as you had chosen. Please stop the video and take a few minutes to choose the correct answer. The question is, which of the following drugs is less likely to produce the PRVEP findings present in this study? A. Ethambutol, B. Viagra, C. Isoniazid, D. Penicillin. The abbreviated approach to reading pattern reversal visual evoked potential studies I use consists of 5 steps. I refer to the first step as verification, to the second step as numbers, to the third step as analysis, to the fourth step as interpretation, and to the fifth step as conclusion. Now I will explain each of these steps, starting with verification. In this study, only one average for each eye was determined. Thus, the usual first step in verification, making sure that the two averages landmarked fall within 5% of each other in latency and amplitude, does not apply. Nonetheless, the derivation should be looked at individually. In this recording, only one derivation was used. The electrode of interest was placed at OZ. The second electrode at A1. With right eye stimulation, right sagittal P100 can be clearly seen. With left eye stimulation, the left sagittal P100 can also be seen clearly. So, computer labeling seems correct. Once verification is concluded, we go to the second step, numbers. And for this, we go back to the study. And as you can see, after right eye stimulation, the latency of sagittal P100 is 114 milliseconds. With left eye stimulation, the sagittal P100 latency is 116 milliseconds. Next, we compare the sagittal P100 latencies following right and left eye stimulations. You can see the numbers in this frame. The latency of sagittal P100 following right eye stimulation occurred 2 milliseconds sooner than following left side stimulation. The latency of sagittal P100 following left eye stimulation occurred 2 milliseconds later than following right side stimulation. Now we look at amplitudes. Following right eye stimulation, the sagittal P100 amplitude was 7.2 microvolts. Following left eye stimulation, the amplitude was 6.3 microvolts. The side-to-side amplitude difference was, when comparing the right eye with the left eye, 1.1, and when comparing the left eye with the right eye, 0.8. So this ends the number step, and we move to the analysis. This is the analysis chart. The site of P100 absolute latency is abnormal, which I am indicating by the red X. The latency difference between the left and the right side of P100 was normal. The side of P100 amplitude after left eye stimulation was normal. The amplitude difference between the left side of P100 and the right side of P100 was normal. The left parasietal P100s were not done. Right sidal P100 was normal. The right side of P100 latency occurred 2 milliseconds sooner than the left sidal P100. The right side of P100 amplitude was normal. The left to right side of P100 amplitude difference is also normal. Right parasietal were not done. Once the analysis step is finished, we move to formulate and interpretation. This is the interpretation chart. We start by asking if site of P100 pathology is present. The answer is yes. As you can recall, the pathology is bilateral, and since parasietal P100s were not done, we have to interpret the bilateral disease as representing bilateral optic nerve disease or bilateral postchiasmatic disease. So now that we're done with interpretation, we move into conclusions. The conclusion is that the pathology is likely to be prechiasmatic, that is bilateral optic nerve disease, because postchiasmatic lesions are less frequent and a more extensive area needs to be covered by them in order to develop bilateral disease. It is important to remember that the visual pathway in the retrochiasmatic area occupies a much wider area than in the prechiasmatic area. Also, since latency was affected and not amplitude, the optic nerve pathology is most likely demyelinating. As far as etiology, I have included in this frame toxins and medications associated with optic neuritis. Take a few minutes to read them. Other important or at least often asked question in the boards relates to carbamazepine increasing sidal P100 latency, lithium decreasing sidal P100 amplitude, valproic acid decreasing amplitude, although not all agree about this one. This figure was published as an example of valproic acid decreasing P100 in a patient with not previously treated juvenile myoclonic epilepsy. The last comment I'm going to make in this regard is about levodopa. Levodopa in dopamine depleted patients decreases latency. So the answer to this question is D. Thank you very much for your attention.